And here we are. So good morning, everybody. It is March 28th. It's Friday. It is a Florida EMS webinar. I'm filming from somewhere not in Florida, but I didn't want to miss today because Eric Van Dusen and I've gotten to know each other over the last several years, and we last met in Indiana in French Lick. If you haven't been to French Lick, you got to go. We had the opportunity to break bread. I learned a lot about him. Uh, he is, he hails from South Dakota, from I think I'm saying it right, Eric Yankton
Yep, currently in Yankton.
in Yankton EMS, flight paramedic, simulation expert. And when we got to talking, he said that he does a lot on OB emergencies, and I said, please come on the Florida EMS webinar because we really need this information. So, without any further ado, Eric, if you want to make any further introduction, um,
Sure.
please, my friend, take it away. I appreciate you coming here.
I I appreciate it. Thank you very much. And I'm grateful for the opportunity to be able to present today. Um, in South Dakota, we had a mobile simulation truck that actually traveled we had three of them, and I was in charge of one. And I was the only person on the crew that really delved into wanting to do OB. And we not only did EMS fire-based OB training, but also hospital-based. And so I was working with obstetricians in their realm of specialty. And when I had several of them make comments of, I learn a truckload when you come, I'm like, that's kind of strange considering I'm just a medic. But from the flight world, we got to fly with the maternal team and NICU team. And we live in a very rural frontier environment, and so the chances of us encountering this stuff is high. um, but when you look at the demographics across the country, I also spent a year in Vegas working with training medics in the valley. About 50% of the deliveries were at home. And so when do we get called for EMS? When things go sideways, and when things go sideways, we need to be really prepared for it. And so I was excited. Peter asked me to present on this, and so we'll jump into it. And of course, my title is I always imagine this. I have a twisted sense of humor because I work in EMS. Most babies technically head out. You got to remember, I'm a dad and I'm a grandfather, so I have bad dad jokes all the time. And it's strange because I have a lot of folks that are like, "You're unique because you like to do OB training. Number one, you're a male. Number two, you're a medic." And so I just try to dive in know as much as I can about the subject matter. So I've also worked mainly hospital based, which is going to tie the two pieces together because we're the front line of healthcare. And so what can we do to bridge that gap to get our patients from the pre-hospital environment to the hospital environment in safe conditions and prepare their team for what's coming in? Again, I've never had a baby. I usually challenge all my listeners when I'm doing talks. How many of you have delivered a baby? And hands go up. I'm like, you're a dude, you've never delivered a baby. We are there to assist with the delivery. And that is our job, is to be a coach and to assist with that process. So I can't describe what it's like having a baby. I'm not going to pretend to. However, it's funny because it's so easy, you can do it in the back of a taxi, and that's why there's so many babies born, and there's so many that are born at home or on the way to the hospital or wherever the circumstances may be. About 90% of all deliveries go without any resuscitative efforts. Things go pretty naturally. Our job is just to show up when and watch for those signs and symptoms when things do go sideways. The number of deliveries I've been involved in, we only had one extensive resuscitation. It was a 23 weeker, 680 grams, and we were able to resuscitate it. One of the most intense codes you ever run. As I'm doing compressions and ventilations on this 680-gram kiddo. Very focused, but very simplistic. Most of us have learned our sample history. The one thing I want to highlight here are the medications. We actually had a stint of circumstances in South Dakota where through the hormonal changes of pregnancy, moms were being put on some antidepressants. And what we found out is um, babies would come out with some respiratory compromise, respiratory suppression. And so if you happen to note on their medication list or history that they're on any antidepressants, that you should be prepared that there's a chance the baby could come out with some respiratory compromise. When we start talking about the illicit drugs, the study came out in 2020 is the last one I actually saw. They're saying one in six babies were born with neonatal absentee syndrome. Um, that's one every 54 minutes, which is a little higher than we want to see. And being from the center of the country, rural, we're still seeing that even in our neck of the woods as well. So nobody's really immune to it. Um, most of the medics that I ever dealt with, they wanted nothing to do with OB. Their theory was duct tape their legs together in diesel. Some things that you can do if you do not want to try to deliver in the back of the ambulance, give them a fluid challenge, causes smooth muscle relaxation. It's very simplistic. It's in your skill set, easy to do. Have them do some breathing techniques. Some agencies have the tocolytics. If you remember the acronym, it's not my time. Indomethacin, nifedipine, magsulfate, terbutaline. I used to work for an agency. We used terbutaline for both respiratory compromise and OB, and I've had to use it a couple different times just because they were pre 37 weeks, and I'm just not comfortable delivering before 37 weeks because there's no surfactant in baby's lungs yet, and I don't want to have to work a baby in the back of the ambulance by myself. Ectopic pregnancies, you got to keep in mind any female of childbearing age, and you're talking from the age range of 8, 9 up until mid 40s with abdominal pain, you have to have a thought process that there could be an ectopic pregnancy or OB relation to it. As you can see, there's several different areas in the diagram or in the picture there that cover the different areas of that. Let me laser pointer, not highlighter. 70% of them are ampullary, and then the rest of them drop off dramatically. And then you can see off to the right side of it some of the causes that cause ectopic pregnancy. And Peter and I had a conversation about DES, or they call it this stilbestrol. It was a medication used from 1948 to 1971. And so this is actually going to come out of my slide deck at some point in time because no one's ever going to hear about this. It was the very first drug scandal in the United States. They were giving it to pregnant moms, trying to minimize the risk of ectopic pregnancies and spontaneous abortions or miscarriages. And it actually increased the chances of having ectopic pregnancies and having complications. And so they've stopped using it. However, the children of these parents, and so if your parents were, having kids in the late 60s, early 70s, there's a chance that their kids would have childbearing complications as well. So at some point in time, it's just not something you're ever going to hear about again. Cord complications, one of the few times that we can interject. We want to try to keep the baby's head from compressing the cord in there. Sometimes we can see the cord coming out of the vaginal canal. We've always been taught you place a gloved hand in there trying to prevent the baby from engaging into the pelvic girdle, which is good. Bladder emptying is more of a hospital setting. It's not something we typically do in the EMS world. We can give tocolytics like the terbutaline and nifedipine and things like that if you have those. But we want to try to protect the cord, and we want to try to avoid palpation of the cord because sometimes it can cause some vasoconstriction, which is going to cause a little bit of compromise with baby. But basically, we need to get them to the hospital. This becomes one of those you need to get diesel so they can go in and do a C-section. The funnest scenario I ever did, I had 5 physicians that I was running them through, and they had to push the pregnant mom with the baby prolapse cord all the way through the hospital down to the surgical suite and slide her over, and they had no nursing staff to help out. And all the nurses are watching me follow them go down the hallway with these physicians and are like, you must be pretty powerful, dude, to be able to get these physicians to do this. I'm like, no, they're playing the game and they're playing it well. It's kind of fun to see. One of the things that we also talk about extensively in the pre-hospital setting when it comes to OB is placenta previa. I always talk about taking a latex balloon, drawing a smiley face on it, and blowing it up. And as you blow it up, yes, the face gets bigger, but sometimes that face shifts depending on where you draw it at. As the placenta starts to develop in the uterus and the uterus grows through the weeks, that placenta can migrate. And so if they've had prenatal care and they've had partial placenta previa, it can migrate up out of the way, and they can have a normal vaginal birth without a lot of complications. Now, I want to talk about this just briefly because placenta previa, I was always taught that you have bright red bleeding and no pain. And the difference between that and placenta abruption is you have pain and no bleeding. That's not necessarily true. And I want to point it out in the next slide deck or in the next couple slides here for you. But you can see here, this is where we would talk about a normal placental, where it attaches to the decidua bassalis. Down here, placenta previa, this is a complete. We're not going to do anything with this in the field, but they're going through the laboring process. We need to get them to the hospital and let them know kind of what we're seeing for signs and symptoms. You can see this partial placenta previa. If we give this another couple of weeks, this placenta may actually migrate up and out of the way, but you may still see some bleeding with that. And so something to keep in mind. Other placental complications, placental abruptions, decidual bassalis is actually the point. There's 4 different deciduas within the uterine cavity, but this is actually where the fertilized egg attaches, and it's the weakest point. And I'm going to talk about that with another complication coming up. But it becomes weakened, it detaches from the uterine wall and starts to collect blood. And as that weight starts to increase, it starts causing more of the placenta to tear away from the uterine wall. And you can end up with complete placenta abruption. Again, this is typically seen with no external bleeding. They do have extreme pain with it, but depending on where the placenta has attached to the uterine wall, you can end up with bleeding. So the 2 differentials is placenta previa is typically painless. Placenta abruption, they're going to have pain. There's 4 different classifications for placental abruptions. Asymptomatic and mild, you're really not going to see anything. All their vital signs are within normal limits. Typically, baby's doing fine. So it kind of falls in line with your different classifications of shock. And then you hit your class 2 and 3, which are your most severe. And we've got to be stepping and fetching and getting them going where we need to go. This will also tie into postpartum hemorrhage, which we'll talk about coming up as well. Cuvular uterus, also known as uteroplacental apoplexy, is associated with placental abruption. So I wanted to throw this in there. One of my maternal nurses actually flew for a gal, and she had this. What's interesting is when you start looking at the statistics on cuvular uterus, they typically will tell you it's benign. There's nothing super significant about it. There's no complications. However, 1% of the cases are life-threatening, and mom will need a total hysterectomy to offset this. The maternal nurse that I was working with had flown for a gal, and she started to massage the fundus. And because they delivered baby, there were some complications with it. And as she was massaging the fundus, her entire abdomen started to turn black and blue. And I know that they get a little aggressive with massaging the fundus, but that's not normal. And so actually it creates bleeding and ecchymosis throughout the entire uterus, creates bleeding complications, creates a breakdown and clotting cascade, if you will. And so they can either have massive hemorrhages or they can increase a risk for a pulmonary embolism. So something to keep on mind. Watch out for your respiratory drive on your patients. Talked about abruption a little bit. Talked about the decidual bassalis. I'm just going to jump into this one because this is something that was never taught in paramedic school to me. So you can see that a normal placenta will attach to the endometrium here. Placenta accreta will actually grow through the endometrium and start to attach itself to it. And then you can actually get placenta increta, where it starts to grow into the myometrium, which is going to be a complication that you're not going to end up delivering this placenta pre-hospital setting. They probably need to go in for a surgical consult. And then you can also end up with placenta percreta, where this actually grows clear through the uterine wall, through the serosa, and can actually attach to organs near where the uterine's attached. And they find it quite common that it attaches to the bladder. And so if mom happens to note that she's had some bloody urine, I would have a high index of suspicion that that might be a complication. Again, this isn't something that we're typically going to physically see, but you have to have a high index of suspicion if things are just not lining up in your assessment of your patient. Preeclampsia and eclampsia, the numbers on this are actually on the rise. Um, I know that we talk about preeclampsia and eclampsia in EMS quite often, and so it's just one of those things. Keep in mind, preeclampsia and eclampsia can last 6 to 8 weeks postpartum. And one of the scenarios I used to run is I would be standing there holding this baby, and mom is having headaches and all the signs and symptoms of preeclampsia, and people just weren't putting the two and two together of how long it can last. We actually had a couple of hospitals change their entire system of instead of just doing a well baby check a couple of days after delivery, they would start doing a mom well-being check and start looking for these signs and symptoms to make sure that they were not missing them. And so that was a really positive thing that we saw come out of providing simulation. Some of the signs and symptoms we're looking for preeclampsia and eclampsia, they've got some hypertension. Both numbers are equally important. Proteinuria used to be a finding. They're kind of moving away from that one, depending on your provider or when they were taught. But we're still looking for that excessive weight gain, edema, uh, not only in the lower extremities, but possibly sacral area and stuff. And then they'll have those neurological findings of the photophobia, headaches, um, the right upper quadrant pain causes there's that two helper mnemonics that we kind of look at in OB. One is for preeclampsia and eclampsia because it affects the liver and the enzymes and stuff, and it can cause an enlarged liver, which is going to be hard to palpate in a pregnant female. You may or may not be able to pick it up, but if they're having right upper quadrant pain, that could be a finding for preeclampsia. And then obviously the eclampsia, they're going to go into seizures. Never a good thing to see. I've only seen it once, thankfully. Don't want to see it again. But we want to minimize their sensory overload, protect the neurological a little bit. And there's your help mnemonic for this one. They're looking at the hemolysis, elevated liver enzymes, and low platelets. If you have ALS, obviously we're going to give some mag sulfate. If you carry labetalol, you can consider it. We don't want to bottom their pressures out or drop it too quickly. It can also have an adverse effect, so bring them down slowly. You could also consider hydralazine or nifedipine if you carry either one of those two. This is kind of a hot topic for me. When you start looking for the active labor sessions, we're looking for cervical dilation and effacement. EMS should not be doing these. There's been medics fired within the United States for doing this. It's kind of like doing triage on trauma patients. It's all subjective. We're all going to have a different theory, and unless you do it regularly, we have no business doing this. So I just throw this in there to say, don't be doing this unless you're medical director and you're specially trained on it and you've got the blessing to do it. You don't want a lawsuit because it will end up being a sexual harassment lawsuit. Shoulder dystocia. Actually, my stepdaughter, her last child, she ended up with shoulder dystocia, and she's not a small girl. Decided to do a water birth, was in the bathtub. They figured out she's having shoulder dystocia. How do you get a 300-pound female out of a bathtub slippery wet? It gets be complicated. And so we watch for those turtle signs. We need to be intervening every 30 seconds to get these relieved. So we put them in the McRoberts. That's the first one we're going to want to do. So legs up and back as far as we can. Have them move. Bring them legs down and then just get that pelvis moving. Sometimes being simple is easiest. Just get the pelvis to move. By her rolling over in the bathtub, it actually reduced the shoulder dystocia. She was able to deliver without any issues at all. You can also go to the suprapubic pressure. Make sure you're pushing down and towards the nose of the baby. We're trying to roll that shoulder over is what we're trying to do. If those aren't working, then we can consider the Rubin maneuver 2, where you're basically sticking two fingers in and you're just manually trying to rotate that shoulder. Some physicians will reach in and grab the armpit and try to get that arm to come up because it rotates that shoulder. And sometimes that's all it takes for the shoulder to come dislodged and prevent that shoulder dystocia. The wood corkscrew method is actually two fingers on the anterior side and two fingers on the posterior side. And you just literally lefty loosey, righty tighty, try to unscrew them and get them to pop loose from the vaginal canal. This is all dependent on your medical director of how far they want you to go. Keep in mind, our job is to assist. Our job is, I live in a world where we do calf pulling, where you hook up chains and literally start pulling calves. Our job is not to do that with babies. Our job is to get moms to push babies out. And I understand that they get tired, but sometimes we have to get a little brash and get them to push. Um, I put the slide in here and most people start laughing. However, it's not uncommon. And when I go out to do trainings, our mannequins have a sensor for the amount of force that you should actually pull traction with. And it's 30 to 50 newtons. And I usually just stop there and see what people have to say. Well, 30 to 50 newtons is about 6 to 11 foot-pounds of pressure, which is equivalent to basically you have a tennis shoe on and you go to pull your shoe off. It's not a lot of force. If you get to over pulling on those, you can cause brachial plexus injuries, Erb's palsy. And you can see the date on this, September 13th, 2023. I'm guessing they didn't pull the head completely off as probably an internal decapitation. And there was more than one case in 2023 that I was actually studying up on. So again, we need to coach moms on they need to push babies out. Our job is just there to assist with that delivery. And you can see what happens when we get to pulling with too much traction. It causes that brachial plexus injury, which can get to be a problem. So, postpartum hemorrhage is another thing on the rise. If you're not carrying all of the medications, which most of us are not, but a lot of us are carrying TXA, so that's your one tool here. And I know visiting with Peter, they're going to blood. So TXA and blood in that realm are going to be the best thing that you can possibly do until you get them to the hospital for intervention. I mentioned the Bakri balloon and the Jada only because the Bakri balloon, I'm not sure if it's going to be in the EMS scope of practice anytime soon. The reason being is the device runs about $3,500. It's one-time use only, and it's only been physician privileges for insertion. But you can utilize this for postpartum hemorrhage, both vaginally or C-section. Postpartum hemorrhage is defined by 500 mil blood loss, vaginally or 1,000 C-section. But it basically goes in and tamponades the entire uterus until they can make the determination of what they want to be able to do to offset this. The other device that is newer out there is the Jada. It basically creates a vacuum and vacuum sucks the uterus down in to make sure it's getting tone and everything like that. The problem with this device for EMS providers is it comes with its own special vacuum system. You can't just turn it to the wall vac on the side of your ambulance and hit suction. It doesn't work that way. And so I'm guessing that the cost prohibition is going to be a little extreme for us to be able to use. But we can notify them because a postpartum hemorrhage patient can bleed out in less than 8 minutes. It's like dealing with a trauma patient. And depending on how you're doing your TXA drips, it used to be a lot of people where it's 1 gram in a 100 mil bag over 10 minutes. Well, you're behind the 8 ball. You need to be throwing everything you can, plus the kitchen sink at these patients to make sure that they don't bleed out on you. So, APGAR scores, these are kind of retroactive anymore. They're a great tool, don't get me wrong. But let's be honest, how many people have these hanging in there? They're charting everything minute by minute by minute of what's going on. Probably not. You're doing it all retroactively. So make sure that when you do a delivery, you're checking the Duncan side of the placenta because that ties into your postpartum hemorrhage. If there's retained placenta, that's an open vascular bed, and moms can have a lot of bleeding still within the uterus that you may not see externally that you need to keep an eye out for. So, and I know was asked to keep it about 20 minutes. I went just a few minutes over, so I'm going to see if there's any questions. That's my down and dirty. I could literally talk on this, I think, for 2 hours, but we'll cut it short.
Eric, that was an amazing primer, and you went into so much. I think so many areas that not many of us talk about, at least amongst our medical director meetings, etc. So I think this gives us a lot of homework. I do want to bring in Dr. Pepe because several of the topics that you mentioned He's actually brought to the fore the last Eagles conference we had down in Hollywood last June. He made it big, probably several hours worth of this discussion. So, Dr. Pepe, can you give us some information on maybe last year, and then do you have anything planned for this year's
Well,
Eagles?
sure. I mean, we're to continue this. The fact that this is a priority for the Secretary of Health, I guess they call her the State Surgeon General in California. She's an OBGYN doctor, by the way, and she may be coming to our meeting because of the work we've done. But we've mostly been focusing on reminding paramedics that in the postpartum period, you don't know it's the postpartum period. Sometimes if you come upon someone having a seizure, a 28-year-old woman doesn't look pregnant. So, but we need to put that as part of our our question is that, baby recently, and then that hypertension in the field we generally don't treat, but when it has to do with these guys, whether postpartum, prepartum, we got to be very aggressive about treating. So we're kind of focused on that. We also had some meetings about precipitous deliveries at that time as well by Chris Colwell, et cetera. So we're into this, but I'm going to tell you, your talk here today, I wouldn't mind having you do a little bit of a shortened version of it for our Eagles meeting here that we have every Friday that's coming up in about 3 minutes. And I'll have you back because this was a great presentation. And what I really like about it is that it's hands-on. You're doing it, and you've got, you can tell us what's happened, and you can say, they can tell us in the book that there's no pain and yet there's bleeding, or the other way around. Like you said, there's exceptions. So I thought this was a fantastic presentation. And I hope to pass this around to other people. Peter, after you get the recording, if you could do it. I did have one question. I want to emphasize this. The issue is that paramedics have been fired. And when you were saying that, I think it's because they were making an inspection to see if there's dilation or whatever, and that was considered. I guess in our training we're saying leave it alone. But can you tell us the reason why? I mean, it makes sense to maybe look for things and see how far along they are, from a medical point of view. But is it out of our scope of practice, and why were people fired?
It actually came out of the state of Ohio, and it was 5 to 6 years ago. There were two medics dealing with a female that happened to be pregnant, and they did a cervical dilation and a effacement check. And in that particular state, it was determined, and the patient actually pressed for sexual harassment charges, and so they were let go.
Okay. Okay. So and do we know what happened? Did they get a criminal or some kind of civil a punishment?
That I don't. And it goes back to building a rapport of explaining to your patients exactly why you're doing what you're doing,
Right.
building a trust and explaining why you need to do that. And as a male,
Yeah.
taking care of a female patient, I'm always very conscious about that. So I don't set myself up. It's having those conversations rather than just doing some of the things that we don't take the time to explain to our patients because we just feel that they're not going to understand.
Right. So I just wanted to bring that because that's a really interesting point, and that we do tell people not to do that, but there's some sense to doing it on certain circumstances. I like your answer and how you approach that. You're a real world guy, so thank you. And if people don't know what it's like to be in your territory where there's very little resources and it's OB deserts, that kind of thing, right?
Yeah, most of my interfacility transfers when I started were an hour and 40 minutes, 2 hours.
Ah, that's
I mean, that's completely normal.
baby
So
catching time. Okay. Hey,
yeah.
last thing I wanted to mention was that thanks for talking about the TXA. And right now we're very focused on trying to not give the TXA more complications happen when you give it later. But if you can give it right away, like the 2 grams or whatever you're using up front one time, that's fantastic. And as far as you know, there's not been any problems with that from your point of view, correct?
Nope. A matter of fact, when TXA first started coming out, and I was doing training on this and having conversations with hospital staff and obstetricians, it was not even in the postpartum hemorrhage algorithm.
Yeah. Yeah.
And about 2 years later, it fell into it. It was still at the bottom of the totem pole. But we also talked about all the caveats with the methogen and hemabate and cytotec and things that were getting missed on those realms as well.
Yeah. Let me, if I could ask someone on the call, John Kramer, if you're still there. I don't know if you've switched over to the other side, but John is giving plasma, like some of the things we're talking about, spray dried plasma in the future, where it'll have a 2 year shelf life, and and also would it be available for at that time? And is it indicated and okay to give a pregnant woman? Are you still there, John? Well, that's a good question, and I wanted to make sure what we're doing. I think
Yeah.
it's not going to be a problem, right, Peter? But
Yeah.
yeah,
100%. Yeah. Yeah.
TXA, and I just wanted to have someone else do it. But I better switch over. But nice job, Eric. Send me his information, Peter. I'll have him on.
I will connect you.
Yeah,
Yes. Yes. 100%. Thanks,
good
Paul.
job.
Great,
This was very
great
nice,
comments.
Peter. Thanks for having that.
Thank you.
Okay, see you later.
You got
Thank
it,
you very
Paul. Thank
much.
you. And so, Eric, the questions are coming in hot and heavy. Let's go with Dr. Parmar. Janelle, go ahead, and then we'll go to Mike out in Canada. Go ahead, Janelle.
Awesome. Hey, thank you. Thank you for the presentation, sir. This is great. Do you have any information about breech deliveries in pre-hospital setting, like footlings, and what we could tell our medics to do if they see a foot sticking out, and what's the kind of a management recommendation?
So I'm not saying you can't deliver a breech out in the field because it happens, and those things you can't necessarily control. Again, if you're trying to bide some time, even if there's a foot hanging out, there's some things that we can do to try to get them to the hospital, depending on how far you need to go. If you're
Off for this one.
if you've got tocolytics and stuff like that, or you've got a tocometer so you can see how baby's doing, that changes the entire persona, because if baby's not stressed, we don't necessarily have to do anything, keep it simple. But you can deliver a breech baby out in the field. If it's an arm, it's an entirely different thing, because then it's like a transcending, and you're probably not going to be able to deliver that one in that particular case. But a footling breech, it can be done in the field. It's just it comes with a higher chance of risk. And so high risk, low frequency events, it just gets to be put people in a really uncomfortable position. But there's, speaking of frank breech, butt shows up first. You can still deliver that. It's just going to cause some probably additional trauma to mom, and we're not doing episiotomies or anything like that in the field. It's just going to be a little more traumatic delivery for mom.
Great
Awesome.
question.
Thank you.
Great answer. Thank you so much. Mike, our friends from Lethbridge, Canada. Mike, go ahead and unmute yourself, and if you want to ask your question, great question in the chat.
Here, great presentation. Here in Alberta, Canada, we run into our community midwives quite a bit, and we have a really good, close working relationship with them. It didn't start out great, but engaging in that collaborative care model is the key. And I'm just wondering if you guys or you folks run into midwives and how you deal with that.
Dealt with several of them here within the state. We don't have an abundance of them. However, in Vegas, it sounds like they run rampant. And I don't mean that bad. There's a lot of them out in the Vegas area. The problem with that is depending on what their certifications are, what their requirements are, it changes that entire dynamic. And it doesn't take much to get a certified midwife, a doula license in some of these states. And so they're very ill prepared, which is why we're getting called in those emergencies when things go sideways. Though we know statistically most deliveries go pretty much uncomplicated, but when we see an increase in postpartum hemorrhages, preeclampsia, eclampsia, those things, when we see those numbers on the rise, it should be a concern to us of, are we working with those folks and bridging that gap?
And someone in the chat mentioned that they come into Northwest Arizona all the time. We have several home births go sideways, and I think many of us on this call can attest to that fact. But again, I think that society has moved in one direction. You have these major celebrities who are doing that. It's become a thing. I mean, there are many Home Depot tubs that we show up to in Palm Beach County and Broward County, and second floor apartment.
And unfortunately, I think COVID had a big play in that, because they wanted the family there for the birth, and the hospitals were not allowing that at the time. And so people are just deciding to do it at home, and they're just like, hey, we can do this. And it's cheaper. We're not having to go to the hospital to do it. And it's like, yeah, but there's a whole lot of things that can go sideways. And if they do, Um, I want to make sure that you're sitting there with that blessing that it's been gifted to you, and not going to lose it. So.
Yeah. Let me go to my co-host Tanner Smeda. Tanner, love to hear your thoughts on this great talk by Eric.
Sure. Yeah. And thanks again for coming on, Eric. I have one question for you. So it sounds like you do a lot of simulation and education for both in-hospital and pre-hospital clinicians. And so the question I'd have is, when you go out into the community and you interact with these healthcare providers, I'm sure they say to you a lot like, oh, I really could have used this 3 months ago on a call that I was on, or maybe even people coming to you, after the fact and say, hey, I just put your training to good use. And so with that kind of feedback, what do you think is the most useful thing for us to take away from this presentation? So if you had to give one tidbit, whether it's a maneuver for shoulder dystocia or whatever it is, what do you think is utilized most frequently and also seen most frequently in the field to kind of balance there?
Honestly, try to keep it simple. When it comes to like shoulder dystocia, we have them at McRoberts, or their legs are backing out as far as they can. And one of the obstetricians that worked at our major center in Sioux Falls, very calm under pressure. He's like, just bring her legs down and in and back out. And it rocks that pelvis. You don't have to throw all the meds in, because once you start throwing meds in things, you're not sure how they're going to respond. And so if we can do some simple things first and offset it, and we just start to advance. I mean, it's like simple healthcare. You start off with the basics and you work your way up to the point where you're getting to where you need to go. And hopefully at some point within that algorithm, it's resolved. Um, I was doing a simulation at a hospital one day, and I did postpartum hemorrhage. We got the Bakri balloon out. We talked about where their medications for postpartum hemorrhage were at, which were clear down the hallway, not in their rooms. And literally, I did a morning session, and that afternoon I was repeating a session for a different group, and they had a postpartum hemorrhage with the morning session that afternoon that they were dealing with. And so from that, they moved all their medication. So it's central, it's right there, it's easily accessible. And so you just have to look at your practices. Just because that's the way we've always done it doesn't mean that things shouldn't change.
And I'm actually going to kind of springboard off of Tanner's question because we still have Doug on the line. Doug is driving, so he's in by audio. But my question for you, Eric, is you have been in this mobile van. You've done a lot of training in hospital, out of hospital, and the question is, how do we get this education out at scale? At the beginning of the show, Doug mentioned that the NMSP, in association with ACOG, is putting out kind of some guidelines for best practices, et cetera. So let me bring it to you first, and then we'll go to Doug next. This type of training at scale, do we all have to buy the OB mannequin? Can we watch the videos that Arthur Wolf just put in the chat? What's your, if you had a blank check and you can write it out, is this hands-on? Is this in person? Is this video? How do we scale this out to hundreds of thousands of people?
To scale it out, it's really just doing what we're doing right now. It's getting the information out, and then being able to, because we were fortunate in South Dakota to get a grant from the Helmsley Charitable Trust to purchase these trucks and go that route. And there's been numerous states around us that have as well. There are other states that are duplicating it. But when you're covering the eastern half of South Dakota, southwest Minnesota, northwest Iowa, you only get to hit those places a couple times a year. And so they don't get to see it a lot. And if they miss it, they miss it. You don't have to have $100,000 mannequin to push a baby out to do some of these simulations. You can do it cheaper as long as people are vested in why. And so you have to set your scenarios and the education up to where they're vested in pull things in why you're doing what you're doing, and set it up that way.
So let me bring Doug in on the conversation. Doug, are you able to unmute? And then if you want to respond to Eric, and if you want to elaborate for the people who weren't here earlier on what the NAMSP has in store coming in the next couple weeks.
Sure. Thank you, Peter, for the heads up so I could pull over to a safe spot and anticipate this. So first of all, for the for those of us that are not in the 10 or so states that are Helmsley states, let me just say we're very jealous. I've seen the simulation vans or buses that are being talked about here in South Dakota, North Dakota. They're amazing. But as was stated, that gets to still a fraction of the folks out there. I think on the physician side. Well, first let me say that ACOG, American College of Obstetrics and Gynecology, recently put together a set of guidelines for EMS care of obstetric emergencies, and they're very good. They were done with members of NAMSP and other organizations as representatives on their writing group, and those have been endorsed by NAEMSP as well as some other major organizations. And so I think those guidelines are a great start because they're out there. They sort of give the best science at the time right now and what we should be considering to do. Dissemination is always the trick. And so NAMSP is doing a webinar in a couple months now, free on Prodigy for all of our NAMSP members, but those are always open to EMS clinicians also. The other thing is that I'd mentioned NAEMT is involved, and when these guidelines are out there, these are what then become things that are put in the various NAEMT courses. They'll help guide the things that go on in those courses. They'll help guide hopefully the SEMSO national guidelines or national model guidelines that many agencies across the country turn to look for the best evidence-based protocol development. So, I mean, I think there are many ways that can get out there, but it really, there's not one single answer. It has to go out in many, many ways.
Yeah, agreed. Thanks, Doug, for that, and we'll look forward to that. We'll definitely push it out through all of our channels. Another comment I wanted to make, Eric, is something that has been something I've been very interested in for many years is the cord clamping. I've been fascinated by the fact that the American Heart Association, as recently as the last guideline, recommended 30 seconds. The WHO has recommended 3 to 5 minutes for many years, waiting until the actual cord stops pulsating.
Yep.
Because people, I think, fixate on that cord and clamping it and cutting it when you have a baby that has to be resuscitated, and you're reducing the chances of this child being resuscitated by taking away the lifeline called the umbilical cord. In the 2024 ILCOR, which came out in November, they did this. I mean, everyone should read it. It's a really long, they looked at all the studies, and now they moved it from 30 seconds to 60 seconds. Even though the study that they reference show that if you wait 2 minutes to clamp the cord, you can reduce mortality by half. It boggles my mind that they're now at 60 seconds. Anyway, my protocol say 3 to 5 minutes, or wait until the cord stops pulsating. What do you recommend, and what do you think about this inconsistency between what the rest of the world is doing and what they recommend for us to do?
Well, and it's funny that you bring that up. I truly believe that delayed clamping is fine. It does everybody, it gives you a chance to take a deep breath, assess what's going on. I know some agencies that they aren't going to clamp and cut the cord until the placenta delivers. They're just going to let it ride. I don't have any issues with that. However, I have seen where all of a sudden you're dropping baby way low or way high, or when they do go to clamp the cord, they do cord stripping. And I've seen polycythemia vera directly stimulated in the baby because of stripping of the cord. And a little bit is okay, but you don't need to strip the entire thing. So I tell people 6 to 7 inch tail. That way, if we need to do an IVC, it can be done. We can trim it up, get some fresh vein, insert the catheter, blah, blah, blah. However, I recommend the delayed cord clamping because statistically best scientific practices are truly showing that wait till it's done pulsating, buy yourself some time. We just get in a habit of feeling like we have to do something. And so we're going to do this now because it's the next step.
Yeah. Okay, good. I'm so glad to hear that you're in that agreement. Um, Hopefully people are watching The Pit because not this episode that dropped yesterday, but the one that from last week. My wife and I watch it religiously. But the one last week, they actually showed the McRoberts. They showed a full-on delivery on like, national TV. It was pretty darn real. So if people, it's interesting to see how this is making its way into mainstream media. Um, I want to see if anybody else, we have a lot of really smart people on the call. Anybody else have any comments? I see one of my paramedic students is on the call, Jordan. Dr. Lee's been doing this for many, many years. Chief Ditnick. Anybody want to make some final comments? Dr. Ingram, Dr. Arbona. Got a great group today.
Yeah, this is Sam Naglia. First question, is ACOG going to address, or do you have any insights on optimal transportation
Oh yeah, transport.
securing
Yeah,
techniques? I mean, the classic fight is, how do you transport the newborn and mom? Two
great
units,
question.
one unit. There's no technology that really has the answer.
They don't. And then when you start looking at the safety standards of ambulances and how you're going to transport it, I mean, historically, we've just put baby in mom's arms and transported. And then all of a sudden you end up in an accident, and that's not the right course of action either. And then if you run the risk of mom having complications, now you've got a complicated mom, but two patients in the back of the ambulance because the baby can't do anything for itself. What are you going to do with baby? Um, so in those cases, I want some additional resources. I mean, even if you can have additional team members in the back of the ambulance, okay. If not, have a second rig take baby while you're dealing with mom. But we also know that most cases, and this is where people will hang their hat, most cases are really uncomplicated. Everybody's fine. So we're just going to transport. Why utilize this other asset over here and tie it up when do you really need it or not? But when you look at the liability standpoint of it, that'll also play into it as well.
Yeah,
It's
and
no
before,
coincidence. Yeah.
no, go
Doc, I
ahead,
was going
Sam.
to say, it's
Finish
no
your thought.
coincidence. It's no coincidence that under the traffic laws of almost every state in the union, when that baby comes home by law, the baby has to be secured in some type of car seat.
Yep.
So that means they need to leave in a car seat, but they can't go in a car seat or
Correct.
Right.
equivalent security device.
So Sam, that's a great point you bring up. I do know because we've looked into this that for the healthy baby, the baby comes out, everyone's happy, and then they have these slings, right? That you sling to the baby. That's one thing.
Yes.
But then you have the PD mate, the OCR, all those other devices. Um, but what if the baby's a 28 weeker, 30 weeker, that type of
Correct.
thing? That's a whole nother story. And I'm not
Yep.
so sure we have the answer to that. But Lou, I see that you came off, you're showing your face, and clearly we'd love to hear your thoughts because you always have so much great insight. Take it away, Chief.
Just a related thought. So the mobile simulation center is great for a large area. I ran a sim center for College of Medicine in our area. So when you have a more densely packed area, we had a full simulation center. So we did OB simulation, both for the medics in the field, which increased their confidence, and the OB nurses. Then we could do more complex scenarios, also NICU training. So we kind of transitioned and did both of that. So it's more feasible in a urban area with money to set up a simulation center where people can come to you instead of the expense and the travel and everything in a more rural area of going to them.
What is the right cadence? I want to ask you, Lou and Eric. So, obviously we're fire-based here in South Florida, and we have the fire calendar, right? And then they typically give us the hot summer months for EMS. But during those times, we're doing our cadence of the alphabet courses and blah, blah, blah. What is the right cadence for OB training at a department, a pre-hospital department?
I firmly believe that the things we do rarely should be worked in once a year. When you talk about advanced airway care, when you talk about something like OB that we don't do enough, I can count on one hand the number of babies I attended in the field. That once a year it should be worked in. Doesn't have to be a 4-hour training. It could be a 1-hour training, but just going through, and I know my own confidence, again, with a handful of deliveries, that doing it on a regular basis. At first, I was facilitating with the OB nurses doing the training or their educators. Then it reached a point when they had me doing the training. I'm like, well, wait a minute. But that increased my level. So by doing it regularly, the things you don't do regularly, if that makes some sense, it helps increase their confidence. So when it does happen, they're more ready for that.
And Eric, what's your thoughts? And then I'll throw in a comment after you go.
I absolutely agree with what it's kind of like CPR. You're talking about a high risk, low frequency event. And so we need to just brush up on it, not just talk about it. And people disengage because they're like, I've got this. It's the same thing. But going back to our previous conversation, how to get this information out. People don't want to change if they don't have to change because they'll just take the path of least resistance and familiarity. But as the standards change, how do we get them to engage? And so we've got to get that information out of why it's changing and the science behind it, and then implement it into the education side. And here's the problem is the educational side, we're typically 10 years behind the science. The textbooks and those things, they're typically 10 years behind getting that stuff out because publishers are still trying to move the current books that they have.
Yeah.
Just one follow-up, Peter. Also,
yeah.
Sometimes you can bring the mountain to Mohammed. So you can just as easily for something like this, put the mannequin on a stretcher, go to the firehouses. Hey, we're going to take a half hour out of your time. We're going to go through a delivery, let you all practice once and move on to the next one. So it doesn't have to be a major sim van. It just needs to be a van or some vehicle that you can fit a stretcher and a mannequin in the back of, and everything you need for that can well be done mobily.
A lot of the simulations we did in hospital, that's what we did is we loaded the mannequins in the back of a Suburban, and I could load two side by side on cots and take all the equipment in the Suburban. It's cheaper to get them there. And we were playing within their house. There's a vested interest if you're playing in their house because they're familiar with all the equipment, where things are at, and you can show pitfalls of where changes can be made.
Right. And Lou, you read my mind, and this goes back to Tanner's question. And Tanner said, if there's one thing, right? So in Palm Beach County, and also I see my battalion chief of EMS here, Chief Mayra is on the line, who's amazing, is I'm a firm believer in exactly what you said. Now in Palm Beach County, I have EMS captains, I have about 30 of them, and there's one per battalion. So there's 10 on shift every day, right? What we've been doing is bringing those EMS captains in, giving them the training, we package it up, and then over the next month, as they go to different department, right at the table, at the kitchen table, or on the floor, they're doing a training that lasts about an hour or so, and we have all the points. Here's what we want to go over, and it's not like the grand scheme of everything, but it's like Tanner said, like here are the things you're probably going to see if you go on a call tomorrow, right? So I'm a big believer in bringing the mountain to Muhammad. I love that, Lou. That should be a title of your next article, because I think that's where EMS education should reside, rather than in Palm Beach County we have 1,500 medics. I'm going to bring everybody to headquarters? No way, right? So we have to push it out the other way, and I think that's the way to do it. Let's see. Okay, so I think we've been through a lot. I know Dr. Pepe's probably anxious to get everyone else on his webinar. Eric, this was incredible. I will put you in touch with Dr. Pepe because clearly he wants you to present something similar like this on maybe next week's Eagles, which is happening right now. Feel free to jump on over. I see somebody put something in the chat. Okay, Jordan says thank you. I will definitely put this on YouTube. And I'm sure we're going to get a lot of views on this one as well. So, Eric, thank you for coming through for me, my friend. And
thank you for the opportunity. Appreciate it greatly. It's an honor.
Yeah, and hopefully we'll see you again. We can break bread again. So, thanks everybody. And actually, before we go, Eric, I would like to give our guests the last word. So, give us the final thoughts. Here we are. We're just trying to make a difference. Like, what are Eric Van Dusen's final words for us here on the EMS side?
My goal in life is to leave this industry better than when I found it. And by trying to educate people on best scientific practices and the changes that are coming. So the citizens that we care for get the highest level of care. That's what's important to me.
Great. That's a great way to end it. Thank you, my friend. And thanks, everybody. Please join the Eagles webinar, which is in progress. Use the link on the side. If you want to get CME, it's there on the side as well. So have a good day, everybody, and stay safe. Thanks, everyone. Thanks, Tanner.
Thank you.
Good seeing you. Thanks.